Your skin color shouldn't matter, but when it comes to getting a diagnosis and treatment for a child with special needs, sadly, it may be the only thing that counts. Recent studies show that if you are a Black or brown parent, your concerns regarding your child's development are likely to be ignored and a diagnosis delayed by years. If you try to speak up, you are likely to be labeled pushy and aggressive. Today, we're talking to researchers whose shocking new studies have Black parents livid. Also joining me are parents who are fed up with the inequitable system. And later in the show, I go one-on-one with a school superintendent to find out what it will take to get special needs kids back to school. All coming up next.
Live from Los Angeles, this is the Special Report.
Often, the difference between living a healthy life and sometimes the difference between life or death boils down to access to health care. Data reveals that race and class play the largest part in healthcare accessibility. These barriers directly affect the diagnosis of autism and other special needs. And even in 2021, as we are hyper-focused on eliminating systemic racism in systems throughout this country, these pernicious barriers persist in African American and Latinx communities. Autism affects 1 in 54 children in the US and is equally prevalent in Black and white children. But more than 100 years after autism was first discovered by a Swiss psychiatrist, a country that can land a car on Mars can't seem to figure out how to eliminate structural barriers and treat all kids equitably. What is the cost of racism to the United States, and will calling it out by name with respect to kids with autism and other disabilities, will this create a pathway for change? Here for our leadoff panel are the nation's leading autism researchers. Dr. Alice Carter is a clinical psychologist and professor of psychology at the University of Massachusetts, Boston. Dr. Frances Martinez de Pedraza is a postdoctoral associate at Florida International University and a policy fellow at the Society for Research in Child Development. And also joining us this morning is Dr. John Constantino. He is a professor of psychiatry and director of the Intellectual and Developmental Disabilities Research Center at Washington University School of Medicine in St. Louis. Needless to say, the doctors are in the house. Good morning, doctors.
Good morning.
Big mouthful, just announcing all of you all and your accomplishments, but I think we got through it. So glad to sit down with all of you. Autism is personal for me. Anyone that knows me and follows me knows that I have a son on the spectrum. We'll be talking about him and my struggle as a parent, but also as a community leader and an advocate. These studies, the new studies produced by both of you all as researchers, are really, really interesting, and our whole team thought worthy of an entire hour so that we could educate folks about what's going on around autism research. So I want to start with you, Dr. Carter. You and your team, which includes Dr. Martinez, recently published a story about autism disparities. Can you just tell us briefly what your findings were?
Sure. So our story was actually motivated by findings back in 2012 that highlighted racial and ethnic disparities in the Part C early intervention system in Massachusetts. So even among families who had reached out for help and connected with services to get early intervention for their children, they still had significant Black and brown kids still had significant delays in getting a diagnosis of autism. So we thought that this was an easy place to start because these were families already connected to a service system that was sustainable. So we partnered with 3 early intervention agencies that were serving a high percentage of Spanish-speaking families and also had very high percentages of immigrant and just very diverse clientele, and trained them in a 2-step screening process. First, everybody worked with parents to fill out paper and pencil questionnaires that were screeners for autism and also collected information about children's other social, emotional, and behavioral needs. And then if kids screened positive, either based on the questionnaires or parents were concerned or the early intervention providers were concerned, we trained the providers. So we're still in the system in the community to do an observational screener with families. And then if the observational screener was positive, meaning that kids were at risk for autism, our team in the university did a comprehensive diagnostic and developmental evaluation. And basically what we found, and our everything was done in Spanish and English, because we really were targeting Latinx families where there were big disparities. And basically what we found in our first paper, just looking within the agencies we worked with, was that we were able to reduce health disparities based on race and ethnicity. And then when we did fancier analyses, comparing our intervention agencies to comparable agencies in Massachusetts, we found that we actually increased detection of all kids by about 1.8-fold. So almost twice as many kids were detected for autism under the age of 3 when they were in our intervention agencies versus our comparison agencies. And we were particularly successful for Latinx and Spanish-speaking families, where there was a 3-fold increase in kids identified. And these are really big, meaningful differences in terms of the numbers of kids identified. And it also suggests that we can make this happen. I think all of the agencies, even after our program was over, our funding from NIMH was over, continued to use the screenings. They were having trouble, though, I will say, connecting to diagnostic services once the university component of providing a diagnosis was taken away.
You and the work that Dr. Martinez did in Boston focused on Latinx communities. I know, Dr. Constantino, your work in St. Louis has focused on African American families, and I was shocked and quite frankly angry, I guess, when I read the findings of your study. Just tell us briefly what you found in the research that you were doing with Black families in St. Louis.
Right, Areva, and I really appreciate your throwing down the gauntlet and comparing, what's possible of a Mars landing versus what's possible for, the children in our country. What we observed was triggered by an initial study that was epidemiologic in scope across the entire U.S., which showed that that the prevalence for autism in the community that's getting diagnosed, even though it's getting diagnosed late and the services aren't good, importantly, is now equal for Black and white children and Hispanic children. The prevalence rates are equal now. And the problem was when those epidemiologic data from the Centers for Disease Control came out, what they showed was that among Black children, if you had autism, if you were one of those 1 in 54 children in the US with autism, the likelihood that you also got saddled with intellectual disability, which is mental retardation, what we used to call mental retardation, was twice as high as for white children. And I'm not talking about a small amount here. The rate is 22% for white children. It's 45% for Black children in the US. So it's enough to have autism, but then to have also intellectual disability compounding that it's a terrible disparity. And so historically, people explain that away. They made excuses for that, well, African-American children and Latinx children are, because of the disparities in diagnosis and they're not getting picked up, the reason why they're more often seem to be more severely impaired is because we're only picking up the severe ones. Mm-hmm. But now that's not true anymore. That we know who the children are, and we can say we can identify all of them in the community, and this disparity existed. So we went in and we asked about the other usual excuses for why a child would end up with not only autism, but with an intellectual disability on top of it. Mm-hmm. And we looked at poverty. We looked at even genetic factors, background factors that run in families, and none of them explain the disparity. And so what the burden of proof now is that it looks like that exactly what Dr. Carter's talking about. It's one thing to, we know that we can pick up these cases early, just because, as you said, the mothers were identifying the cases, and Dr. Carter has shown how you can identify cases. But once those cases are identified or screened positive, they have to be diagnosed, and then they have to be availed access to early intervention services that are specific to autism. And this is where we find there is just a parting of the waters. There is no level playing field as far as that's concerned. And so that's what we think is the next highest priority to move forward.
You know, I'm grateful, Dr. Carter and Dr. Constantino, Dr. Martinez, for your work. But I just feel like in the last couple of minutes, you guys have told us what these studies have found without using the word race. And we've got to be able to call that out. And that was what was so shocking, I think, and so upsetting in so many ways, but also refreshing, is that article that was in the National Pediatric Journal that called out structural racism as it relates to the diagnosis and treatment of kids with autism.
Right.
And so I'll ask you, Dr. Martinez, are researchers told, you guys told in college or grad school, don't use race as a word? Because I'm a civil rights lawyer, and we scream race, when we wake up in the morning. So is there something about researchers that you guys don't like to call out racism?
Yeah. Thank you so much, Areva, for asking this question. I think it's really key. And I think one of the main challenges in our field of autism has been that we really are kind of late in the game, I would say, in terms of starting to really look deeper into these differences that we've known for a long time that exist between different racial groups and between different minority groups in the United States. We do know there are differences in access. We do know there's difference in the quality of services children on the spectrum who come from families of racial and ethnic minority backgrounds face, right? And so I think one of the main reasons why we haven't been talking explicitly about racism and structural racism in different systems is because in some ways, researchers tend to sort of report what we are measuring. And what we are measuring right now have been exactly that. Differences, like groups look different. And we haven't started to look more deeper into what are families' experiences? Are they really, when they are going through that diagnostic process, having experiences of racism? We haven't really started looking at that. A few years back, when I was working with Dr. Carden in Boston, we started actually looking at that preliminarily. So families who were coming in for diagnostic evaluations, we started asking them how they perceive their early intervention providers. As an important note, in Boston, most of the majority of the early intervention providers are white European American providers. Many of the families that came through our diagnostic process, 73% of them were identified as families of color. So Latinx families, Black African immigrant families, and other families of color. And 35% of them spoke different language other than English as their primary language. And I'm highlighting this to highlight sort of the difference between children who are being served and the workforce of early intervention providers. And one of the things we did was ask families how they perceive their early intervention provider in terms of their cultural humility, right? Like their connection or their competency in serving families of color. And we also asked providers the same question, sort of so that they could reflect around how they were doing in working with families of color. And one of the things we found was that providers perceive themselves to be more culturally competent than families are perceiving them. And why is this important? Because actually we saw that how families rate their providers in terms of their cultural humility is associated with how much services they're actually accessing, early intervention services they're actually accessing, as well as how they're rating the quality of those services to be. So, I think it's important to start looking beyond those differences between groups, which is an important starting point in our field, and sort of like look deeper at different factors that continue perpetuating sort of like structural racism within these systems of care, like early intervention.
Yeah, and the reason I guess I'm so upset about the findings is because your research study, Dr. Constantino, that was done, we talked earlier before the show with Dr. Dan Geschman here at UCLA, found that Black kids are still being diagnosed as much as 3 years later than their white peers. So when my son Marty was diagnosed over 15 years ago, those were some of the same statistics that Black and brown kids in particular were being diagnosed 2 to 4 years later. Those were the numbers at that time, 15 years ago when Marty was diagnosed. And so here we are, 15 years later in 2021, still with that enormous diagnosis gap. And I guess I have to ask you, what are you all learning about these barriers, and which are the most intractable?
Yep.
Is it, geography? Is it redlining? Is it housing discrimination or limited available workforce like Dr. Martinez talked about? Is it language? Is it Medicaid reimbursement rates that are so woefully inadequate for diagnosis purposes? Which of these structural issues are you finding to be, the one that we need to be the most concerned about?
Yeah, well, this is a great question. And Areva, I think even more than the issue of Black versus white time of official autism diagnosis, one of the things that, you asked as scientists, why don't we using the word racism and call it what it is? I couldn't agree with you more. I also think that as scientists, what we want to do is find out exactly how is racism affecting the process of health and the acquisition of service. This is exactly your question. So in the situation about Black versus white diagnosis, they're actually, in the United States right now, they're only about 6 months apart. The real statistic is that the lag time between when a mother of a Black child goes to the primary care person and says, I think my child has a problem or has a delay. From that point of time, it takes 3 years. That takes 3 years to get a diagnosis. And that's significantly longer than for white children.
So you're saying the diagnosis time period in terms of getting diagnosis has been reduced to 6 months, but the 3-year lag time is from when the mother first reports.
That's right. That's exactly right. So the disparity in diagnosis time between white and Black has narrowed to 6 months. However, there is a massive disparity, much bigger than that, not only in this issue of the time when mom says they have autism until they get diagnosed, but the service access. So even if you get a diagnosis, that's only a diagnosis. You need service, you need intervention, you need support. And that is comparatively for white versus Black children, then things really, really start to fall apart as far as the disparity gap. So when we did this study and tried to disentangle what are these elements, what we were trying to find out was what was the cause, where was racism, and where were these lags happening? And what we saw was that if you want to focus on a resolution of this, first of all, you have to listen to the moms. Secondly, as soon as the moms say something, you have to make it appropriate and comfortable and supportive and available to them to get a diagnosis, which we've now in a follow-up study shown is possible, just like Dr. Carter's group has shown. It's possible, we can do this, but then they have to get the services. And what happens between even the diagnosis and services is that your opportunity to get the appropriate amount of services is so difficult because of the disparities in the insurance payers and the school systems and so forth. And we have to resolve, this, if there's going to be a level playing field so that you aren't destined, to have these sort of adverse cognitive outcomes, we have to
want something or not using